All right, welcome to the deep dive. Today we're doing something a bit different, taking a specific set of revision notes you've shared on common peroneal nerve lesions.
That's right. We're going to take those notes and really, flesh them out into a proper deep dive.
Exactly. The idea is to pull out all the key high-yield stuff for you, make it clear, make it stick.
It's a great way to learn. Focusing in on one specific area like this really lets you get to grips with it.
Totally. So we'll cover the basics, what it is, why it happens, how it presents, how you diagnose it, and importantly, the management. Everything you need from these notes.
Let's jump in.
Okay, let's unpack this right at the start. What is a common peroneal nerve lesion, according to these notes?
Well, fundamentally, it's just damage to that nerve, the common peroneal nerve.
And that's a branch off the big sciatic nerve, right? Down the back of the leg.
Precisely. It usually branches off around the back of the knee area. And the key thing is damage can happen sort of anywhere along its path. And when it gets damaged, it leads to problems with muscle weakness and also sensation changes in the lower leg and foot, the areas it supplies, basically.
And the notes mention a specific vulnerable spot.
They do, yeah. A really common place for this injury is around the fibular neck. That's where the nerve winds around the top of the fibula bone, quite close to the surface.
Ah, so it's exposed there.
Very much so. It's a key anatomical weak point mentioned in the notes.
Got it. Damage to that branch, often at the fibular neck, causing weakness and numbness below. Okay, so that's the what. Why does this happen? The causes, the etiology.
What's really striking from the notes here is just how many different things can actually cause this.
Yeah, the list is quite broad, isn't it? It starts with the obvious, like trauma.
Right, direct trauma,
Yeah.
things like fractures, especially of the fibula or tibia near the knee, dislocations, that kind of thing.
Makes sense.
But also compression. This is a big one. Prolonged pressure on the nerve.
Like from what?
Could be sitting awkwardly for ages, crossing your legs tightly, or even from things like tight plaster casts or braces put on after an injury.
Okay, so external pressure. What else?
Then you've got nerve entrapment syndromes, where the nerve gets squeezed in a tight anatomical space. Sometimes just anatomical variations people are born with can predispose them.
Huh.
And of course, things actually pressing on the nerve, like tumors or cysts near its path.
Right, and systemic issues too.
Absolutely. Diseases that affect nerves generally, like diabetes, that's a major one highlighted. Also inflammatory conditions, vasculitis, autoimmune problems,
Wow.
and even sometimes complications from surgery or other medical procedures done in that leg area. The notes really show it's vulnerable to a lot.
That variety is definitely a key takeaway. So
Yeah.
linked to that, what about risk factors? What makes someone more likely to get this?
Well, as you'd expect, a lot of the risk factors directly mirror those causes we just talked about.
Okay.
So having a traumatic leg injury obviously puts you at higher risk.
Stands to reason.
Yeah. And similarly, being immobilized for a long time or having one of those tight casts or braces applied, that links straight back to compression.
Right.
Then underlying health conditions are important. Diabetes, again, or other diseases that cause peripheral neuropathy, they significantly increase the risk.
And the notes also mention things like obesity and even your job.
Yes, obesity can sometimes increase pressure points, and certain jobs that involve, say, prolonged squatting or repetitive leg movements that put pressure near the fibular neck.
So it's a mix of injuries, medical conditions, and even just life factors.
Pretty much. They all increase the chance of one of those damaging mechanisms actually happening to the nerve. The notes suggest you should really think about this risk in anyone with leg trauma, tight splinting, or nerve-affecting conditions.
Okay, so we know the what, the why, and the who's at risk. Let's go a bit deeper, the pathophysiology. How does the damage actually, stop the nerve working properly?
Right. So if you think about a nerve as basically a communication wire, the fundamental problem here is that the signals get disrupted. The messages going from the brain down to the muscles, and the sensory signals coming back up from the skin.
The signal gets blocked or messed up.
Exactly. And the notes explain that how this happens can vary depending on the cause, whether it's pressure or a direct hit. But typically, the injury or compression triggers inflammation around the nerve.
Okay.
This inflammation can then damage the nerve's outer layer, the myelin sheath, that's like the insulation around the wire. This is called demyelination.
Ah, stripping the insulation.
Yeah. Or if the injury is more severe, it can actually damage the nerve fiber itself, the axon on the wire inside the insulation. That's axonal damage.
And does it matter which one happens? The notes seem to highlight this distinction.
It matters hugely, and that's a really high yield point from these notes. Demyelination damage to the insulation often has a much better chance of recovery because the underlying wire, the axon, is still intact. The myelin can potentially regrow, but axonal damage to the wire itself, that's generally a more severe injury. Recovery is slower, often less complete. So knowing the type of damage gives you a clue about the likely prognosis.
Right, that makes sense. Damaging the wire is worse than just damaging the insulation. Okay, so the signal disruption leads to what the person actually experiences, the clinical presentation. What's the absolute headline symptom here?
Foot drop. The notes really emphasize this. If you see foot drop, common peroneal nerve should be high on your list.
Foot drop, the classic sign, right? Difficulty lifting the front part of the foot.
Absolutely. It specifically affects dorsiflexion, that's pulling your foot and toes up towards your shin, and also aversion, turning the sole of your foot outwards. There's often weakness in lifting the big toe too, the extensor hallucis longus.
So you can't lift your foot, can't turn it out. I imagine that makes walking quite difficult.
It really does. People often develop a characteristic steppage gait. They have to lift their knee higher than usual when walking to stop their toes catching on the ground. So you'll see difficulty walking, maybe problems with balance. And alongside the weakness, the notes mention sensory symptoms too.
Like numbness.
Yeah, numbness or tingling, typically on the top of the dorsum and the outer aspect of the lower leg, the lateral shin area. Some people might also have pain along the nerve's path.
And over time, muscle wasting.
Yes, if those muscles aren't getting the nerve signals, they can start to waste away, atrophy, particularly the muscles in the front and side compartments of the lower leg. But the key takeaway from the notes on presentation: foot drop, plus that specific pattern of sensory loss on the top of the foot, think common peroneal.
Foot drop is the big red flag.
God.
Got it. So you see these signs. How do you confirm is this nerve and maybe figure out why? The investigations.
Well, it always starts with the basics: a good clinical evaluation, taking a detailed history, asking about potential causes we discussed, like injuries or prolonged pressure,
Right.
and then a thorough neurological examination, carefully testing the strength of those specific muscles, dorsiflexion, evertorsion, toe extension, and mapping out the sensory loss.
So the history and physical exam point you in the right direction.
They do, but the notes really stress that the key diagnostic tests here are the electrodiagnostic ones: electromyography, EMG, and nerve conduction studies, NCS.
Okay, EMG and NCS. Why are they so important for nerve problems specifically?
Because they give you objective information about how the nerve and muscles are actually functioning. NCS measures how fast and how strong electrical signals travel along the nerve itself.
Like testing the speed of the signal down the wire.
Exactly. And EMG looks at the electrical activity within the muscles, both when they're resting and when you ask the person to contract them. It shows if the nerve is successfully talking to the muscle.
Okay.
So together, these tests can confirm that there is a nerve problem. They can help pinpoint where along the nerve the damage is located, assess how severe it is, and crucially help distinguish between demyelination and axonal damage. Remember that distinction.
Yeah, the insulation versus the wire itself. Crucial for prognosis.
Precisely. EMG and NCS help you figure that out. That's why they're so central, according to these notes.
Okay, so those tests confirm the nerve issue. What about imaging? The notes list X-rays, ultrasound, MRI.
Right. Imaging comes in mainly to look for the cause of the nerve lesion once you suspect it's there.
So not to diagnose the nerve problem itself, but to find out why it happened.
Generally, yes. You'd use imaging to look for things like a fracture near the fibular neck, or a tumor, or a cyst, or maybe signs of entrapment, something structurally pressing on or irritating the nerve.
That's a really useful distinction from the notes. Exam and nerve studies diagnose the lesion. Imaging finds the cause. Okay. But as you said, foot drop isn't only caused by this. What else might look similar? The differential diagnoses.
That's a really important point for revision, isn't it? What else is on the differential list? Your notes give a few key ones to consider.
Like an L5 radiculopathy, a nerve root problem higher up in the back.
Exactly. That can definitely cause foot drop, or even a lesion affecting the main sciatic nerve before the common peroneal branches off that would usually cause weakness in more muscles, including knee flexion and ankle plantar flexion.
Okay, so a broader pattern of weakness.
Right. The notes also list anterior compartment syndrome. That's more about muscle swelling and pressure within the compartment, often very painful. Sometimes lateral popliteal nerve lesion is used, which can be similar or refer to a more distal injury, and even a lumbar plexus injury, higher up still.
So Quite a few possibilities. How do you tell them apart based on these notes?
The key thing the notes imply is looking closely at the pattern, the exact muscles affected, the precise area of sensory loss. For example, L5 radiculopathy often involves weakness in hip abduction as well, and maybe back pain. A sciatic lesion has that broader weakness. Compartment syndrome usually has severe pain, swelling, tense muscles.
And the nerve tests help here too.
Absolutely. EMG and NCS are often crucial for differentiating. They can help localize the problem specifically to the common peroneal nerve at the fibular head versus a nerve root or the main sciatic nerve.
Got it. The specific pattern and the electrodiagnostics are key. Okay, changing tack slightly, how common is this? What do the notes say about epidemiology?
Well, the notes are quite upfront that specific data just for common peroneal nerve lesions, particularly in the UK, is a bit limited. So we don't get a precise X number of cases per year from this source.
Okay, no hard numbers then.
No, but they make the general point that nerve lesions, including this one, can happen to anyone across different populations, different age groups.
Right.
And while we don't have specific incidence rates, thinking back to the risk factors we discussed, trauma, diabetes, certain occupations, it suggests that while anyone can get it, it might be more frequent in people exposed to those risks. So it's definitely something you need to be aware of in clinical practice.
Fair enough. Okay, so let's move to management. Once you've diagnosed it, what do you do?
The notes outline a few main strategies, and often you'll use a combination depending on the cause and severity.
Starting with the conservative approach.
Usually, yes. That's often the first step, especially if the damage isn't thought to be too severe or if it's something like compression that might resolve. A big part of this is physiotherapy.
Exercises and rehab.
Exactly. Exercises to maintain range of motion, strengthen the muscles that are still working, and hopefully encourage recovery in the weak ones, trying to retrain function.
Okay.
Also, ankle-foot orthoses, AFOs. These are braces that help support the foot and prevent the foot drop during walking. They can make a big difference to mobility and safety.
Like a physical support.
Yes. Pain management is also considered if pain is a significant feature. And importantly, preventing secondary problems like stiffness in the ankle joint or skin breakdown from altered sensation or braces, that's part of conservative care too.
So therapy, support, pain relief, and preventing complications. When would surgery come into play, according to the notes?
Surgery is generally reserved for specific situations. If there's a clear structural cause that can be fixed, like a cyst or a tumor pressing on the nerve, then surgery to remove it would be considered.
Makes sense. Remove the pressure.
Or if the nerve is physically entrapped by a tight band of tissue, surgery can release that pressure. That's nerve decompression. If the nerve has been severed, nerve repair might be attempted. So it's really aimed at fixing an underlying anatomical problem or repairing significant damage.
So conservative is more about managing symptoms and supporting natural recovery, whereas surgery is about fixing the source of the problem or the damage itself.
That's a good way to think about it, broadly speaking. And the notes also mention another key aspect, managing underlying factors.
Ah, like if diabetes is involved.
Exactly. Getting blood sugar under tight control is crucial. Or if obesity or occupational factors are contributing, addressing those through lifestyle changes or workplace adjustments is important. Treat the whole picture.
Right. Makes total sense. And finally, the notes mention follow-up.
Yes. Regular follow-up is stressed as really important throughout the whole management process, monitoring progress, seeing if treatments need adjusting, providing ongoing support and education.
Okay. Which brings us nicely to the likely outcomes. What's the prognosis and what are the potential long-term complications?
Well, the notes say the prognosis is pretty variable. It really depends on those factors we've touched on. What caused the lesion in the first place, how badly the nerve was damaged, that demyelination versus accidental injury thing again.
Right.
And also the person's overall health and how quickly they receive treatment.
So what's the best case scenario?
The good news, according to the notes, is that many people do see significant improvement or even make a full recovery, especially if the cause was something transient like compression that's relieved or if it was mainly demyelination.
But it's not always a full recovery.
No, unfortunately not. The notes are clear that some people may be left with persistent residual weakness or sensory loss that doesn't completely resolve, even with treatment.
And what kind of problems can that lead to down the line, the complications?
These really stem from that persistent weakness. Things like muscle atrophy, the muscles wasting away from lack of use, Chronic pain can sometimes be an issue in the area the nerve supplies.
Okay.
And obviously, ongoing gait abnormalities due to the foot drop, which makes walking difficult and significantly increases the risk of tripping, falling, and getting injured. All of this can lead to quite significant functional limitations impacting daily life, work, activities.
Yeah, you can see how that would have a big impact. And the notes mention follow-up again here.
They do. It's highlighted under management and again when discussing prognosis and complications. And maybe this raises a final important thought based on these notes.
Go on.
Given that potential for long-term issues, what does that really tell us about the importance of ongoing care? It's not just about fixing the initial problem, but about that continued support, helping people adapt, managing any lasting effects to maintain quality of life.
That seems absolutely crucial, doesn't it? It might not just be a one-off fix. It could be more of a journey for some people, needing that long-term management.
Exactly. That continuity of care seems vital.
Well, I think we've really dug into the core of these revision notes on common peroneal nerve lesions. We've covered the definition, the surprisingly wide range of causes and risks, the how of the nerve damage, the classic signs like foot drop, how you investigate and differentiate it, the management options from physio and braces to surgery, and finally the outlook and potential long-term considerations.
Yeah, hopefully we've pulled out those key high-yield points from the notes in a way that's helpful for you, whether you're revising or just wanting to understand this condition better.
We certainly hope this deep dive based on your notes has been useful. And remember, if you are preparing for exams, consolidating this kind of focused knowledge is so important. For more resources and, crucially, practice questions to test yourself, you might want to check out passthemsra.com and freemsra.com.
They're great sites for putting this kind of knowledge into practice for the MSRA.
Absolutely. Well, thanks for joining us for this deep dive.
Thank you.